There we go. There we go. Now we're recording. Okay, so again, we're going to work our way through table 5-4, dealing with the spasticity patterns. We're going to look at it as if a patient has these, and then work our way on how to fix them. Just some ways, things we can do to intervene. So the first one deals with a rhomboid problem. So the patient, so usually you'll see these post-stroke, TBIs also as well. You'll see patients come in and they will have the retracted and downwardly rotated scapula. Now, 90% of the things we do when we're dealing with orthopedic injuries is trying to get people to have stronger rhomboids, stronger middle traps, because they help to stabilize the scapula. They pull us back. I call it putting the scapulas in the holster, like holstering a gun. They help to holster the scapula and put it back in its right position. But when it's that position all the time, so what I want you to do is try to, with one of your scapula, we'll do the left side. I want you to retract it as far as it'll go, and now drop it down as far as it'll go. Now hold it there. Now, try to move your arm, but hold your scapula there. How far does your arm go? Doesn't go up very far, does it? Try to abduct it. How far does it go? Doesn't go up very far. Try to extend it. Doesn't go back very far. So it hinders the function of the extremity if my scapula stays in that position. So I need the scapula to be able to, that was a weird sound. I need it to be able to protract and upwardly rotate for reaching in arm activities. If it doesn't have that ability, then I'm hindered on my abilities to flow and function. So it's really important that we treat patients who have this weird scapular position. So let me get a volunteer, please. We'll walk you through some of the treatments we'll do. One of my favorite treatments. Doesn't matter. If you're breathing, you can use it. Yeah, lay on down. Head this way for me. Probably be easier. All right, and then, so we'll get you laying on your side facing me. So one of the first things I do, if I have this patient and they have, so let's have you retract, downward rotate, and the scapula is locked into place. One of the first things I try to do is start facilitation. Actually, it's probably better if you lay on the other side so they can see me better because it's more functional. All right, so the scapula is downwardly rotated, retracted. What I'm going to try to do is take the arm into my left arm. I'm going to use my right arm. I'm going to grab on the medial border of the scapula, and I'm going to work on protracting the scapula and getting it to come forward. You may have to fight against it, just like he is. You're going to fight against it. You want to definitely get your table higher than mine. And what you want to do is be able to get it in range in protraction and upward rotation and just kind of work the scapula in that plane to get it mobile as best you can. So I'm supporting his arm so it's not just dangling and hanging on my thigh. And now I'm just protracting the scapula, trying to pull it forward as much as I possibly can. You can also do counter rotations if you want to stabilize the pelvis and use your forearm and help to pull forward. Feel that? Yeah. So that's another way you can protract the scapula. I mean, you're trying to get the patient moving. It's going to be a fight, but you're trying to get them moving. The third one that I love to do, let's say he is, so let's get you on your other side here. We'll show them this one. I'll tell them this. If they're side sleepers at night, I want them to sleep with a protracted scapula. So I don't want them laying directly on it because it's going to naturally want to pull back. So you want to teach them to sleep with the arm pulled out. So I almost tell them to grab with the other arm, pull here, and pull the shoulder out get a little bit of rotation, and now lay flat. You good there, you just lay flat there. So when they sleep, the scapula is protracted even in their sleep. It's just a good, comfortable way. If he had a pillow, he'd be comfortable. There we go. See, I do care. All right, so that's what I would do with them, even in sleeping. All right, so grab a partner. Let's practice that. Side lying, work on protraction, pulling that scapula. Your job, if you're the patient, make your arm fight against it. Make them pull forward. Make them work. It's going to really help them to feel it. Yeah, so you want her to kind of pull against you so it makes it easier.
Here.
No, good, good,
Okay,
good. Keep
is
going.
that right?
So there. So this will lay kind of on your thigh.
Okay.
This one reaches around, grab the top, and now you're grabbing medial border, but you want her to stay on her side. Don't let her see how she wants to naturally roll away. You want them to stay on their side, and you just, get the scapula moving. You bend into it. You have to use the knees, use the body. I'm coming. Yep, go ahead, keep on. No, keep the position. Don't let her go.
Okay.
So let her kind of rest on your thigh. Yep. Yep, this hand here, top. Yep, and now get a little bit more forward. You have to get that leg down, stagger your stance, and you're bending your body into it. There you go. Bend the body.
Okay, I got a question.
Yes, ma'am.
So with like this,
Mm-hmm.
you said rest it on the leg, kind of like that.
Mm-hmm. Because once you're pulling the scapula,
It'll just come
it
down.
just rests on there. Mm-hmm. Good. Well, let's check it. Let's check it. Mm-hmm.
And just pull.
Well, no, so you don't want to pull on the arm because it'll dislocate. So you want the arm to rest on your thigh, and this arm is on the medial border. And now your body is in a stagger stance, and you're pulling with your body. Your arms are helping, but your body is doing the work. There you go. I'll take it, Logan. There you go. Not killing them, but you're definitely protracting that scapula. Right. I like to kind of get a little bit of in-range pressure to kind of hold it there, to fire that Golgi tendon organ, to release that muscle spindle. Absolutely. It helps. Get it to in range. Let it stretch. Good thing about it, you can't break it, you can't kill them.
What'd you guess? I felt it moving. It freaked me out.
What? You didn't think it was gonna move?
I was like, whoa. I was expecting to look down and she'd be dead. I was like, oh my gosh.
You can't kill them. Protracting the scapula doesn't kill people. It actually feels pretty good. If your scapula, a lot of times I also use this technique with patients who have trigger points underneath their scapula. They love this technique. Oh yeah, that's a good one. Oh yeah. That one and that one there. I love that with patients with trigger points. That. Just get underneath. So right there now. Trunk. There you go. Oh yeah, right there. You're too far from her. Your patient feel like you're gonna kill them. So let her arm rest there on you, on your thigh. So that leg stays forward, staggered, so her arm feels comfortable. And you're staying pretty close, but you're still using your body.
What about this arm is coming down? I'm supposed to lay on it?
Yeah, it's fine. Because it's healthy. It won't give you any problem.
Better or worse
Yes, sir.
for the adjustment?
Yeah, let's check it out.
So like this okay, right? Just have them resting like that.
No, you can. Yeah. That actually worked. No, you can. Either way. The only reason I like to do the arm forward is because it's been protracted for so long that can bind them up. So I want to get, just dropping the arm gets you protraction naturally. So that's why I like doing this. Now, if I'm doing the scapula, if I'm doing a orthopedic scapula, I do that. So if I'm orthopedic scapula, I'm doing this. Lock, hold, control, retract, pull, pull, pull. But if I'm doing a logic, because the scapula has been bound and retracted for so long, I actually want the arm down here because it's forcing protraction even before I go to grab it. So it's now I'm just coming in and doing my thing with it. And now getting him more to in range than what he was able to get on his own with just the arm hanging down. Make sense? So yeah, so I like the other one for the orthopedic. I do, I love it. So trunk, forearm, press,
Oh, okay.
pull.
Yeah, that's what I was trying to get you to do.
There you go.
Oh, okay.
Yep. Rotate.
So like that.
Press, pull. Oh yeah, life changing. Hmm?
I was picturing
Oh.
sleep. Is that right though? Like that?
Yeah. It's out. Feel the shoulder out. Yeah.
Is my hand placement right?
On the ASIS pelvis. Oh, which one are you trying to do the pull? Forearm. Right
okay,
here.
forearm.
And now pull with your, there you go. Push with your trunk. There you go. Now you're trying to get some stretch. That's a good one there. You go home tired, but your patients love you. They're like, oh God, oh my scapula. Oh, my arm hadn't moved like that in 20 years. You're amazing. Oh man. Just scapular protraction. It's just different ways of doing it. My job is to show you 1,000 ways to skin a cat. Putting tools in your toolbox. All righty. Everybody's good? Good stuff? Okay. So the next one is going to be the shoulder. And now these are all in conjunction. So it's not like your patient's going to have one area and all areas free. Now they may have, usually stroke affects the full limb, but it certainly can affect, it usually affects distal to proximal. I don't want to say that. It usually can affect the whole limb. Sometimes you may have a limb where few things are wrong, but for the most part, it usually gets the whole motor homunculus for the upper extremity. So the scapula is retracted. Oh, excuse me. Scapula is retracted, downwardly depressed. The shoulder is going to be adducted to the body. It's going to be pulled into the body. It's going to be internally rotated. Adduction, internally rotated. There's one more. It's three. Adduction. Oh, depressed. So depression is really coming from the scapula, but adducted, internally rotated with the retracted, depressed scapula. So they're like this. And go ahead, you can just, the elbow will be flexed too. This is the pattern of spasticity that we normally will see with the person. When patients come in, most likely if they have an upper motor neuron injury, either due to a stroke, traumatic brain injury, something going on to the brain, upper motor neuron, they're going to have this pattern of spasticity that you will see for upper extremity. Adduction, internally rotated, retraction, depressed scapula. Now that affects, so now let's try that. Retract, depress the scapula. Now adduct the arm into the body and internally rotate it. Now hold it like that. Try to feed yourself. Hard to do. Doesn't really work, does it? So it affects ADL performance. So that's why this stuff is so important, to teach patients how to improve it. It can. If it stays like that, where it never moves, and they constantly hold it like that, they're going to get that fibrous tissue around the joint, and it can lock it in and cause contraction. Shorten range. Now I can't abduct. I can't extend. I can't protract the scapula. Yeah, because remember, the scapula is not a joint. It's just an articulation. So glenohumeral joint will be contracted. Mm-hmm. So with that, usually the goal is going to be to get the person into some abduction with external rotation. So once I facilitated the scapula, the next thing we'll have them do is try to get them sitting up in neutral position. I try to get the arm abducted away from the body, and I try to get it externally rotated. So have them abduct, so this abducts away from the body, and then you can have them externally rotate, or you externally rotate the arm so that they now have weight on it. And I just have them leaning into it. So you can have them leaning into it, or you can have them leaning away. And now what is that doing if I'm doing this? Not really scapula. So think about the glenohumeral joint. So I'm here, and now I scoop my hips to the right. What's that doing to my glenohumeral joint? What position is that putting my arm in? What type of abduction? Yes, that's what I'm looking for. Woo! One more time, say it loud. Closed chain abduction. That's exactly what I'm doing. Closed chain abduction. Working on it without having to do the arm. This may hurt, trying to lift my arm above the head. This may not hurt at all, or hurt very little, or actually feel good, because you're weight bearing on it. You're moving the joint around. So closed chain, I'm actually shifting the humeral head around, getting it to stretch in the capsule, and now I do some closed chain abduction stuff, where I'm moving my body instead of my arm. Yes, sir. Absolutely. That's exactly what you're doing. You're trying to stretch out muscles that are spastic. And the goal is, the best thing you can do is to teach them to do it on their own. So when they're not with you, they're constantly doing it, so that you can manage the spasticity or even minimize it. The more they are doing these throughout the day, the better off they're going to be before the spasticity comes back. So you want them to constantly be thinking about doing this. Every hour of the day, I want you doing something that gets out of that spasticity pattern. That consistent. Every hour, doing something. Every hour you're awake. Now, don't wake up in the middle of the night and I need to stretch my arm. It's 2:30, Mr. Thomas said. I have to wake up every hour, and then I go back to sleep and don't wake up, Don't be that crazy, but every hour you're awake is what I usually tell patients, because you're fighting the spasticity. And even when you're not awake, try to lay in a way where you are battling the spasticity in the way you lay. So you're constantly trying to fight it, because it will fight you. It fights. Spasticity will fight you. So a lot of weight bearing, closed chain abduction. Then once that feels better, I can move to some open chain abduction. Skylar, toss me a towel, please, if you don't mind. The laziness in me just didn't want to get up and walk. So now I can convert my closed chain abduction into open chain, or still closed chain, but now instead of me moving my body, I'm now going to get some movement from my glenohumeral joint, still abducting away, and now trying to bring it back in. So now I have them slide a towel. Getting abduction to the arm and stretching out the joint. That makes sense? It's also helping with a little bit of protraction. So I started centrally, just having them sit, opening that up, moving the arm away from the body, abduction, external rotation. Then we do some closed chain movements of the glenohumeral joint, anterior, posterior movement, superior, inferior motion, just kind of moving the glenohumeral, moving the head of the humerus on the glenoid. That's what closed chain does. It allows me to move, well, actually it's a fixed head of my humerus, and I'm moving the glenoid on the humerus. So instead of moving the humeral head on the glenoid, I'm sliding the glenoid on the humeral head. Does that make sense? So I'm moving the scapula on the humeral head in closed chain. Yes, absolutely. Exactly what I'm doing. And because I'm not trying to fire the muscles around the joint, I'm decreasing that pain and that signaling that I get from trying to do it myself with those synergy movements. So now I'm moving out of the synergy and moving the glenoid on the humeral head. And that helps to loosen up the glenohumeral joint. Then I move from that into some closed chain stuff, still moving the glenoid away from the humeral head. And then I work on moving the humeral head on the glenoid last. I mean, your general motion, anterior, posterior motions, superior, inferior. You're just trying to get every motion that's possible with the glenoid fossa so that it moves on the humeral head. I mean, you can't get them all, but you can definitely get anterior, posterior, superior, inferior pretty easily. Can't get any rotation, but you could. I mean, you could lock the arm in and rotate away, so you can get the rotation. So really, there's no limitation. So yeah, you can get all of them. Only limited by your creativity. Alrighty, so latch yourself into a plinth. Start with that. Position your arm in abduction, external rotation. Weight bear on it. Then start adding motions. Closed chain, moving the glenoid on the humeral head. And then progress. Mm-hmm. Mm-hmm.
So closed chain is external. What you have.
Mm-hmm.
And then you get a towel for the.
Mm-hmm. And you'll feel that. The longer you're staying bearing weight on your arm, you'll start to feel the muscles work. All right. Yes, ma'am. I'm headed your way.
So you can do it abduction, external rotation,
Mm-hmm.
and have them go away from it.
Mm-hmm.
Or you can have them go to it and put weight on it.
No, so I'm not going to it because
Okay.
that's adducting.
That's what I thought. Okay.
So now, once that feels pretty good, now I put it on a towel, and now I have them move away from the body. So now I'm doing abduction with the glenohumeral joint
Okay.
instead of moving the scapula on the humerus. The other two was scapula on humerus. Now I'm moving the humerus on the scapula.
So what's the difference between doing it out like this or doing it out like that? Is there a
Just
difference?
no. So I mean, now you're adding some extension in with it.
Okay.
Yeah, that's it.
But either way, it's fine.
Yeah, I mean, the goal is to try to get as much motion as possible.
Okay. Okay, and so
Mm-hmm.
when you're just like this, it's scapula.
Right. So with this one, I'm just abducting, externally rotating, so I'm getting out of the spasticity pattern.
Okay.
So the spasticity wants to hold me here, but I'm trying to move them out of that. So abduction, external rotation of the humerus moves them out of that.
Okay.
Now I'm trying to facilitate more movement of the humerus now that I'm out of that pattern.
And then this is just the glenoid labrum moving.
No, like the head of the when head of the humerus moving on the glenoid. Yeah.
Okay. End of the
When I'm
humerus
moving,
on the-
because otherwise, if I'm just like this and here, and I'm moving like so, protraction, retraction, that's the scapula moving on the humeral head,
Okay.
closed chain. So now I progress that to actually moving the humerus.
Okay.
Get what I mean? So one is just getting them out of the pattern.
And
One is proximal movement, moving glenoid on the humeral head, and then I'm progressing it to moving the actual humeral head on the
Okay,
glenoid.
so you start like this, then you can go into this, and then you can move it. Okay,
There you go.
I got it.
That's the goal. It's all about progression. All about progression. And the good thing about that position is it's also helping to work on the elbow, because the elbow spasticity pattern is going to be flexion and pronation. Well, that's the forearm. The forearm is going to be pronation. So that position works on not just the glenohumeral joint, it also works on the elbow, forcing it into extension, and it works on the forearm, putting it into supination. So this position works on a lot of things at one time. So I used to love having my patients, just sit like that, sit for a good period of time, and let's fight it. It also works on the wrist. The wrist wants to flex and adduct, coming toward the midline. Now, this is still adduction. So I know you're thinking, wait, man, that's not adduction. Adduction is my ulnar moving toward the midline. But because I'm stuck in pronation, my whole wrist is moving towards midline. Does that make sense? So it's adduction because the whole wrist is coming toward my midline, even though it's not the ulnar border. The wrist is stuck in pronation, so the whole thing comes toward midline. So I'm like this. So you'll see stroke patients looking like this coming in with the retracted hip and the plantar flex foot. And so we're fighting that spasticity pattern by getting them out of all of those patterns of spasticity into the opposite direction. That's the goal. So anything you can do, and nothing works better for helping with spasticity than weight bearing. The body loves weight bearing for treatment of spasticity. So that's why we're getting them weight bearing. We want stuff where they bear weight on it. Repetitions and weight bearing. Best two things for spasticity. Okay. Alrighty, so that's what we would look like for the upper extremity. Retracted, downwardly rotated scapula, shoulder and adduction, internal rotation, elbow flex, forearm pronated, wrist in flexion and adduction, fingers flexed. And the hand is going to be called what we call fisting, where the fingers will be so flexed where it's almost impossible to move. They become so rigid and so hard, they become almost impossible to move when we have fisting. So a lot of times if they have problems with fisting, I would take it and try to open the fisting up. And I'm gonna tell you, if they have problems with fisting, when you go to open that hand, you're gonna get a smell that's gonna literally knock your socks off. Like they're gonna fall down if they're tall. Like, whoo, that's the worst smell I've ever smelled on this side of heaven. Because the fingers have been closed. Imagine holding your hand like this 24 hours a day and never opening it. The amount of sweat and dirt and all kinds of stuff that just constantly inside of that hand, and you go to open it up and it's, whew, good Lord, wow. So just know that may happen if you deal with someone who has fisting. So you have to open it up. I would usually put something in the hand, or OT would make a splint, a resting hand splint, where the splint goes in and it spreads the fingers wide, and then it straps down. So it literally holds their hand like that, and it looks like a molded hand, and it keeps them from fisting. I'm trying to see if we have a resting hand splint. Did we keep one? Let me see if we kept one. Hey, don't you know? Cervical braces. All kinds of splints. I thought we had a resting hand splint. Apparently we don't. Let me see. I used to have a box. Oh, nope. I took the box to OT. Gummy. I'll show you one. I'll pull one up on here so you can see it. What a resting hand splint will look like. Yeah. Good morning. How we doing? Yes, ma'am. All right. So here it is. That's a good one.
To support the flaccid, weak, deformed, or contracted hand, the Comfy Rest Hand provides a contoured fit that is comfortable, practical, and well-loved. This splint is very easy to fit and positions the thumb in abduction in a functional position. Adjust the wrist angle and begin by wrapping the wrist strap to secure in place. We are left with 4 more straps that can be secured anywhere on the splint, allowing for an ideal patient-specific fit. The 5 straps are soft enough to accommodate for fluctuations due to edema. Super soft and removable navy headliner cover is machine washable and treated with antimicrobial barrier for skin breakdown prevention. The Comfy Rest Hand is available in the regular static model or in a deviation model, as shown here, that allows for radial and medial deviation using our unique swivel joint. Let's look here at the swivel mechanism. Open the wrist strap to expose the swivel joint. If you desire movement, it's simple to do. Simply use the provided Allen wrench and loosen the bolt. To secure at a specific angle, lock into place. The splint can be locked into place to prevent ulnar or radial drift and to promote progressive movement. Replace the splint cover and secure the strap. The Comfy Rest Hand, available in both static and dynamic deviation options.
That's a resting hand. Some will have the fingers molded into it, so some OTs will make their own, where the splint is actually molded, where their fingers fit into slots, and they'll strap down each finger if they feel like it, or they'll do just a general resting hand like that. but it's good to help keep the hand from fisting. So you want to always encourage them. Are you wearing your splints that OT gave you? No, when I get home, I forget. No, you can't forget. Wear those splints. Set a timer on your cell phone. Every hour, you need to be wearing it 55 minutes or 50 minutes out of every hour. You need to keep that splint on. It's going to keep your hand from fisting. We don't want it to get stiff where it doesn't want to open. Make sense? So you're constantly working with patients in that way. Okay, now, so next we'll talk about the lower limb. In the lower limb, the pelvis is actually going to be retracted. Retracted pelvis. So a retracted pelvis is going to be caused because of a tight quadratus lumborum. So the QL muscle. QL is found lateral to your paraspinals. So let me show you quadratus lumborum. We'll show it to you, and then we'll teach you how to find it and palpate it. Quadratus lumborum. It is my favorite muscle. Really, it's not, but it's fun. Okay, yep. So that's where it's going to be housed. Lateral to the paraspinals. Trying to see if I can find a good image of it with, here we go, it's perfect. That's the image I want. Yes. Perfect. So these are going to be the paraspinals, the three muscles that come off the spine, the erector spinae. We call them paraspinals. You see those there. Well, actually it'll be over here, spinalis, longissimus, iliocostalis. So those are the three long paraspinal muscles. These are the deep paraspinals. This is multifidus. So these are the paraspinal muscles. So it's going to be buried deep, a little bit deep to iliocostalis, but it's going to be something you'll be able to feel with pelvic hiking. So if you want to, you can do a seated or standing. Really, you need to learn to do it both. But if you take your hand and put your thumb on your spinous processes, come out lateral, that's going to be your erector spinae. You can confirm that by flexing, you should feel it stretch, and then by extending, you'll feel it contract. You do leg extension with it, you really feel it contract. Those should be your paraspinals. Go slightly lateral off of the paraspinals. Now, if you extend, you shouldn't feel as much, even if you extend with the leg, but if you hold there and you hip hike, you'll feel it. That's going to be QL. So it's going to be lateral to the paraspinals. Yep, so little too come in just a little bit. Yep, right, push right there. Yeah, a little bit in, right about here. Yep, now hip hike there. So like here. So don't really abduct. Yeah, just pelvis. There you go. There you go. Pelvic lift. Hip hiking is pelvic lifting. A little too. Yep, right about there. Come in a little bit. Nope. Yep, right about there. Close. Yeah, you're probably right on it. Yeah, probably right on it. Yep. Yep. Yeah, a little bit louder. Come in a bit right there. Yep. Yeah, probably right on it. Man, you feel it? Mm-hmm. Yeah, well, right on it. Spot on. So that's quadratus lumborum that you're feeling there. Lateral to the erector spinae. Right in there. You feel your hip hike, you'll feel it jacking your pelvis up. So it's going to be spastic, which means it's going to be constantly on. So it's drawing your pelvis back and up. Ooh, Lord, I almost tipped over. It's drawing your pelvis back and up constantly. So it's going to make your leg feel like it's shorter. So imagine standing with your hip like this. Makes your leg feel shorter. So because my leg feels shorter, because this is spastic, this isn't going away, the way that I try to reach the ground because this is happening is I keep my foot plantar flex. That's why they always have the plantar flex foot. Shorten leg. Okay, so let's talk about ways to fix QL. Somebody here probably has a tight QL now, even though you're not spastic. Anybody was like you felt tight? A good way to check it. Hold down your pelvis, almost like you're holding your pelvis down. Hold down one side of your pelvis and bend away. See how much bend you have. Mine are pretty good. If you bend, if it's like, I take that back. This right one here is terrible. A little bit. Okay. We'll check it. Don't worry. You're going to find out if it's tight in just a minute. Okay. Give me a volunteer. Come on down. We'll put your head down this way. I'll clean it in just a second. Okay. So the best way, there's a couple of things you can do for QL depending on depending on the status of your patient. If they're really low level, I'm probably not going to be doing a whole lot of crazy stretching. If they're really low level, you can do positioning things to help. You can position their pelvis. So let's say her right one was tight. I would scoot her hips toward me, like so. I would move her legs away, and then do a trunk shift. Whole trunk though. I don't want her rotating, I want her shifted. So I'm gonna grab and I'm gonna shift. So I'm almost gonna hold and shift. So this is for my low-level patient. She can't do a whole lot for herself, but I'm stretching the crap out of QL right now. Just from her laying there. She doesn't have to move. She doesn't have to participate, but it's getting stretched. She feels that. Feel that? Mm-hmm. There you go. This isn't a low-level person, but she feels it. All right, so I do it for 30 seconds to a minute. I come back and readjust them. Good stuff. Way to go. Yeah, everything is moving opposite direction of the QL. So I'm moving my trunk away and my hips away, so the muscle is being stretched at both ends. It originates on the ribs and the disc of T12, L1, and it inserts on the iliac crest. So I'm trying to shift the crest away, and I'm trying to shift the ribs away and force it to stretch. Functional stuff. Okay, so now my patient's a little bit more higher level. I can do something in sitting. This is my favorite one. I do this with my athletes or my patients that come in with tight QL all the time. Low back pain people usually have bad QLs. So roll toward me here. So I have them side lying and then scoop toward the edge here. So I have them side lying. I knee bend to 90 degrees. I'll put the top leg behind the bottom leg. So top goes behind the bottom. And now I let the legs drop down to the ground. And I'm going to support it with my foot. And now, once I get them in that position, bend the elbow, and I have them trunk rotate away. And then I will grab the pelvis with my arm and pull down like so. And keep fighting for side bending of the hip. Trying to get this to 90 degrees. Feel that pretty good. Oh, yeah. Breathe, my friend, breathe. This works. Sure, I can.
What?
You want her to do it. All right, so 90 degrees with the knees. So that's the first part. 90 degrees with knees. I'm going to put top foot behind the bottom foot. So it's like she's laying like this. So top foot goes underneath the bottom foot. Next, drop legs off the bed, and I'm trying to let them hang down to 90 degrees. And they're going to stop somewhere before 90 degrees because she's stiff. This is no different than her doing a side bend. So she's stiff, so it's not going to go all the way. So I take my knee and I brace her and push her into 90 degrees of side bending. So my body weight is doing the work here. So I'm supporting her there. Then I rotate the shoulder, and all I do is add force. So I'm taking my hand, putting it on her iliac crest, and pulling inferior. And still fighting to get the knees in 90 degrees. And that's side bending. That's an excellent stretch. You want to change people's lives who have crappy QLs, do that stretch. They'll love you for life. They're going to sit up and they go, God, oh, my back pain went away. You're a miracle worker. Little old ladies be hugging you, want to kiss you. No, ma'am, I'm good. No slop. Can't do that. People love you, I'm telling you. It's the skill set. If you know how to stretch stuff, you can change people's life. Nah, because it's going to be impossible to stand and do it. Here's why I know. So it's almost impossible to stand and do it unless there's one way you can stretch QL with the stand, and you need a wall. It's going to be you leaning away from it. I'm going to steal this section of wall. It's forearm on, feet away, both feet together, and you literally will lean your entire body into a section of the wall. Well, I guess, yeah, 1 foot in front. So you can get, that's a QL stretch in standing. That's how much force it takes to stretch it in standing. So anything you're just doing where you're twisting, you're just stretching paraspinals. You got to put force on QL to get it to stretch. Like nothing stretches it other than force. All righty, ma'am, come to a seated position. Let's do the last one. So just swing your feet off that way. Now, you can do what you were doing in another way, but it still requires force. So I can have her sitting up, reaching for that area, and now I'm going to apply a trunk force and have her reach even further, like grab the edge of the bed and pull yourself. And now I'm applying force to the pelvis and holding it down. Feel that? So that one works where you're doing a force, and you can do it where you add the force if you feel like you need to do it. I just have them grab the table, like grab that way for me, same way. And now I'm just gonna grab the pelvis and hold down on it, adding force. So yeah, QL loves force. You gotta add force to make QL stretch. All right, let's have some fun. Grab another human. I'm gonna walk around and laugh, because I guarantee you there's some tight QLs in the building. We're about to find them.
Now, if we have lower back pain a lot, that
Could be the problem. It could be tight iliopsoas or tight QLs. I've solved so many people who had back pain that nobody could solve stretching QL or iliopsoas.
So we're going to be working this one, all right?
So, yep. So make sure you pull her
I might need
to,
to be down.
yeah, so get her to the middle, and then you pull her first towards you. So you scoot, and then start moving her, instead of having her scoot. It's gonna be fun.
If the hip starts raising up,
You can push down, yeah. Yeah. Yeah, he's probably not tight yet, but you'll find it. If it's tight, you'll find it. Almost, Logan. Come this way.
Come from the back.
No. Come from the leg.
Oh, that's right.
Here. There you go, Doc. Now you see the difference? You just changed his life. He's like, Jesus, I didn't know that was tight for real. I thought he was lying when he told me I was tight. Yeah. Push on it with your knee. Push him. There you go. Push him in the side bending. Now you're working on something. Grab the bottom shoe.
Okay.
Because that's, So this one, now, right there. Now push him in with that knee. There you go. Now you're stretching something. Hey, you just changed his life. He loves it. Good, There you go. You preaching. Keep pushing those hips in. There you go. She needs it. Now, make her do that. And now you grab here on the hip and pull. Now. Oh boy, I told you it was some tight QLs in here. Y'all thought I was joking. Huh? You got to start from the bottom. Start from here. Oh, Jesus. This is going to be terrible. It's going to be so much fun. Start from here. Push in. Yeah, you got to push in from the hips. Huh? Don't kill him. So get him back on. I'm coming. So start from the legs. You're starting here. And you're pushing there.
okay, but I don't do anything to the trunk.
Oh, yeah. Once you get this straight, then
You rotate.
rotate, then you pull.
Okay.
Yeah, it's a 3-step.
I gotta go around.
No, so,
You gotta push it towards
go, so get down towards his legs, and push his knees toward the center. There you go. You don't have to squat, you just push him forward. So use this leg here and walk his knees up like that. There you go. See how his body started to run? Told you it was tight. Now roll that shoulder. Now take this hand here, hold there, forearm here, and pull down. There you go. And keep fighting. He's too silent. Bring him all the way back up and readdress. Yeah, IT band. That's why a lot of people have bad IT band pain. More so you have her reaching for there, and you grabbing here and pulling down.
Okay, on the hip.
Yeah, so you're on the iliac crest pushing down. There we go. Good there. Telling you, this changes people's lives. I fix more hip pain with this stuff than you'll ever imagine. We good? Come on around. Let's see what you got.
Okay.
Oh, Logan's always fun to stretch. All right.
Top leg on the bottom, right?
Right. Top leg go on the bottom. Yep. Bring them 90 degrees. So pull them up a little bit more. Yep, right there. Now. No. You know, get the leg. So use that left thigh and walk his legs forward. Now you stretching. There we go. Now hold that there. Keep pushing right there. Now have him there. And then so this arm here, there. This arm here, here. Forearm. Use your forearm. Pull down on his pelvis. Oh yeah. That's the face you want to see. It's called an ooh Jesus face. Do it. Push it. So use your knee, push it, keep going. Oh, she's tight. She's terrible. Now, so this hand here, here, and now forearm on her pelvis, pull down. Now you stretch. There you go. Feel the misery? It's not terrible. It needs it. That's why a lot of IT bands are tight. You've been stretched
On both sides
so
now.
much now. You're gonna be limber.
I wonder if my leg is still shorter than the other one.
Probably not. It probably.
Let's check. You ready, Sally? I'm gonna take her shoes off. All right.
More force with the leg. Push it down. There you go. That's what you want to fight for right there. 90 degree.
You sliding. So how can I keep her from sliding?
She's like, because her body's trying to get away from it.
Oh.
So go right before her body moves.
Okay.
Right there. That's where you want to start. And now, yep. And then, yep, there. And just
You know, you still don't feel nothing?
so she keeps
She's
trying
still
to.
sliding. I know, but I'm saying you sliding.
So push on her there. You may have to have a two-person. It's her shirt.
Okay.
It's just now. There you go. Now her body can't run, so she changed her life. She's like, oh God, she ain't joking. It's tight. It's so tight. Oh God. Oh God. No. Oh Lord. Quadratus lumborum. I got my quadratus lumborum. So out of all of you in here, how many had a tight one? Just about everybody. Yep, told you. So guess what's going to happen if your patient is spastic? Theirs is going to be worse because it's constantly like that all day long. Other direction. You're using the other stretch. Yep. So more knee. So use your knee and get her into more side bend. There you go. Now. Uh-oh. And now, so this arm reaches. So this arm here will reach the other way. So this arm, yep. Holding there. Now forearm here and pull down on her pelvis. Be gentle. Don't kill them. But it's fine like this. It's a weird stretch. It's something your body probably has never done. Oh, he's been stretched to high heaven, so he probably won't feel this one. Yeah, no, the other one is the best stretch on this side of heaven for it. Yeah, if he's done that one, he probably won't feel that one. No, they probably won't feel it. If you've done the other one, they won't feel that one. It has done the job, I can promise you. Okay. What time is it? Oh, it's just 11:32. Good. Okay. So along with the hiked pelvis, they're also going to have what we call leg scissoring, where the hip is going to be in flexion, adduction, internal rotation. It's like it's coming across the body. Like, so not all the way across, but kind of like that. Yep. Toe kind of turned in, and it's going to be plantar flexed. And it's scissors. So when they take a step, the leg is naturally going to want to try to come across the other leg into midline. So with that one's one you all are smart enough to figure out. So they're scissored. So you come up with how you would treat this for your patient. If I had scissored leg, I was flexed, internally rotated, adducted. What would you do for me if you were my therapist? So what do we have? 2, 4, 8, 10. Good. Okay. 2 of 5, 5, 10, 2. Okay. So We'll let y'all work in teams. Let's do teams of, well, no, we'll do pairs. Yeah, we'll just keep working on pairs. Come up with as many stretches as you can think of to help stretch your patient who is in this position. I give you 5 minutes. 11:40, we'll go through some. what's called an abductor wedge. And they give they're abduction pillows. They give them away to patients. They don't give them away, but patients will use them if they've had total knee, not total hip replacements, and so it keeps the feet apart to keep them from adducting across the midline. So they make an abduction wedge if we have one in clinic, or you can use pillows to make one that keeps the feet away, so it fights the adduction, the scissoring, and then you can have them have the foot rotated, externally rotated. Sideline, they may be a little uncomfortable because the whole leg isn't supported. They're gonna go, oh, my leg is so tight. But your thinking is in the right direction. So they do make abductor wedges that help patients. So they're even making smaller ones now to keep the knees from scissoring where it doesn't have to go all the way down. They make a side abductor wedge as well. So that's what you're talking about, just offering support between the knees. You'll see a need for this. I tell you, the number one group of people outside of surgical people I would use this for, you probably wouldn't even think about it. Anybody would think about what group of patients would I recommend this for the most outside of people who had just had hip replacements or strokes? Kind of, not really. It can be any age. It's a really weird thing that no one thinks about. IT band patients, here's why. Yes, I told you it's weird. So the IT band on a lot of patients, it depends on the body type. So the body type matters more than the IT band pain. The body type that you'll see that needs this is the person who has wider pelvis, thin legs. So they have a pelvis that has width, but they have thinner legs. So if they're a side sleeper, their leg, the top leg is always in adduction. So you're constantly putting strain on the IT band. So you want to keep the pelvis neutral. The width of the pelvis to the knee, I tell you to 5 legs with a pillow. And that will fix the part. One trip. That's why you hurt. They go home and go, oh, your knees. That's why thin knees. So if you find patients like that, when they lay, Mackenzie might. Let me see. Come on over. Let me see something. It's relevant when you can see it. Just lay on your side for me. Let me see. Yeah, almost. So yes, perfect. So when she lays, her pelvic height is here, her knee height is here. So when she lays, she's constantly in hip adduction as long as she's sidelined. So she's constantly getting a stretch over IT band. So over time, that can start to hurt and ache because the IT band constantly on when she lays down. The way I would fix it is to bring it into neutral. Put a pillow there. So chunk me a couple of those pillows. Yeah. Probably should. Feels a little bit better. Pain went away. Send them home. One treatment. So if they're habitual side sleepers, they can't get away from it. That's usually what I would find. That's usually would be the fix. Just abduct the leg to match the height of the pelvis. Pain goes away. It's pretty cool. So I would give these to a lot of people. Good stuff. Good stuff. Table 1, table 2. What do we have? Give us a stretch. What are we doing to keep them out of spasticity or to reverse the spastic pattern?
Okay, since they're like always internal,
Mhm.
adducted, well, and just kind of, abduct them,
Okay.
stretch like that, or we could do the butterfly stretch like this to help with this external rotation and then
And abduction, yeah. Only thing is it's pushing them into flexion, but it is getting the other two that are bad. So that's not bad. That's not a bad way to do it.
Okay. So it needed to go into extension.
I
Extension, so we didn't. Yeah, we did flexion. Like we did. Yeah.
Oh, the hip is extended. My bad. I'm thinking the other way. Yeah. So that's a good one. Yeah, you're trying to push them into flexion.
Okay, then we had one side.
No, don't do one. No, you can't do more than one. All right, group 3.
So we were thinking like close chain activities.
Okay.
So they can be like this also. I was getting you go back to see. So if they were like this, you would turn the leg like this and like. So work
Weight
on
bear.
flexion.
I'll take it. I'll take it. That's a good way to do it. Weight bearing, leaning into abduction, going away from the adduction, putting the hip in static external rotation. It's good. All right. Table 4. Yeah. Plinth. Yeah. Great for patients. Yeah. Absolutely. You can teach them. I usually would do it with a, if you put them on a pillow that raises the height, if they had a slick surface at home somewhere they can do it on, put the leg on the pillow, gets a little bit of flexion, and just have them work external rotation, abduction, sliding away. Yeah. Table 5.
Straddle with the palms, we just use the belt. So we're going to have the patient laying in supine, and we're going to strap this around their foot. And it's going to be used at home. They'll pull the leg into flexion, abduction, and external rotation.
Good idea. All of these are good. This is great. Way to go. As far as it goes, or that's, oh. I was like, he has the tightest hamstrings on earth. The God Almighty. That's terrible. That's a good sign. Okay. All of them, good ideas. Not much more I can add. That the more you can think about ways to do this, the better off your patient is going to be. The knee is actually going to be extended, but it's extended because they're trying to fight for leg length because the pelvis is retracted. Does that make sense? So you bring the pelvis back in, you can start to work on knee flexion in normal position. So you got to get that retracted pelvis better. Then the foot and ankle, mostly plantar flex and inverted. This is really hard to fight therapeutically. Bracing this is going to probably be your best bet with something like an AFO. So they probably would need an AFO. You can work on strengthening and doing things with it, but it's really hard. Laying down, the foot really needs weight bearing to correct some of its deficits. So you really need to weight bear. So anything laying down isn't going to correct it, no matter how many, external rotation, eversion type exercises I do. I need weight bearing. So that's why bracing usually works a little bit better with the foot and the ankle. Okay? So good stuff. Y'all have worked really hard here. I've had a lot of fun. Any questions? Did you learn something? Very good. Go home and stretch somebody's QL this evening just for fun. Make them cry a little bit. Tell them you love them after that. All right. That's a good lunch break time there. Back at 1, and we'll do the other class. Foot ankle needs weight bearing to correct. So it will either need bracing or an orthotic, like an AFO. AFO is an orthotic, or you maybe can get a brace, like an ankle brace, but that just adds base support. So you'll probably need an orthosis, an orthotic, an AFO to help correct it.
Thank you.
Yes, sir. Fun times. I got a good laugh out of it today. There's definitely some terrible QLs in here.